and we welcome you all back. We're excited to have such a large audience today, and I can see that once again, much to our great excitement, we're seeing not just friends from the United States, but also from Europe, which is just great. And I suspect that we're reaching down to South America once again, which is just a wonderful opportunity to share. For those of us who manage children with rare diseases and skeletal dysplasias, certainly the problem of dental disorders comes up time after time after time, and most of us had absolutely no training in dentistry when we were in medical school. So we are particularly thrilled to welcome Dr. Tim Wright today. Dr. Wright is the Bawden Distinguished Professor of Pediatric and Public Health at the Adams School of Dentistry at the University of North Carolina. As usual, he'll be presenting his talk. We'll then take a break for questions, announcements, etc. And then my understanding is he has a very challenging case, and hopefully we can give him a hand with it. So welcome. And Dr. Wright, thank you for being with us.
Thank you so much for having me. I appreciate the invite, and nice turnout. It's good to see. I saw somebody's greeting from Athens. So hello, and what is it, Kalispera, maybe at this point in time of day? I'm not sure what it would be over there, but yeah. So I'm going to share screen, and does that look good? Yep. All right, good. We get the thumbs up. So that's how we do this virtual stuff these days. Get the thumbs up, because I can't hear at this point. So yeah, so I'm going to talk about dental concerns and issues, some of the more common conditions that have skeletal bone manifestations and concomitant dental manifestations, and some of the challenges that we face in the dental world, and some of our collaborations across the aisle to medical specialists in a variety of areas. So tooth formation, since you didn't get a lot of this in med school, and I know there are some dental people on this webinar as well, but tooth formation is an amazing embryological kind of event. It's almost as complex as embryology for the entire human being. You have terminally differentiated, highly specialized cells that create a microenvironment. They're controlling the influx and efflux, processing proteins and ions, and doing all kinds of remarkable things to end up with these, the development of the hardest tissues in the body. The enamel is the hardest tissue, and this occurs over literally a couple of decades. If you go from in utero, it starts at 6 weeks and goes all the way through, if you count third molars, into late adolescence. So there's a lot of opportunity there for environmental genetic kinds of interactions during this whole developmental process. Yeah, I guess I'm going to use this. Yeah, okay. So from a genetics point of view, we know there are thousands of genes. We've done whole microarray, whole genome microarrays, looking at to define the transcriptome using laser capture to get different cells at different time points in development, and the different tissues, the enamel, the dentin, the cementum, the three main mineralized tissue components of a tooth. So we know that there's a lot of complexity at the molecular level, but we also know that over time there's going to be all kinds of environmental influences on the development of the teeth, just like there would be for the skeleton or any other component of the human being. Nutrition being a critical one, but also physical phenomenon, trauma, infections, prenatal CMV, rubella, congenital syphilis, all those kind of things can impact tooth formation. So clinically, we're seeing that combination of genetic underpinning along with environmental influences over the course of the developmental time frame. There have been some really nice developmental schemes. This is one by Irma Thesleff, Scandinavia, who did a lot of pioneering work in the early development and molecular controls and the signaling that goes on between the oral ectoderm, which is what originally initiates and starts to invaginate into the oral cavity area where the developing tooth buds will be, interacts with the underlying ectomesenchyme, and they do a dance essentially. And they do a molecular dance, and they're sending back signals to each other. They're being controlled by different transcription factors, different growth factors, and it's much more complicated than would appear in this, as most things in biology are. But many of these conditions, or these genes and these regulators, we now know have associated genetic anomalies and that are associated with developmental defects of teeth, some of which also may have skeletal anomalies that may be craniofacial or may be more generalized than that. We also know, my joke with this is usually that this is, my wife and I have gone out for dinner. The point of this slide, and this was a cover on American Scientist, and it's actually one of the dioramas at the Natural History Museum in New York City. But the point of this is, if you look at hominids, and there have been some fascinating recent work in the evolutionary tree of hominids and some of our ancestors from millions of years ago, if you look at tooth formation and the molecular control of this, it is highly conserved throughout evolution. In fact, in if you look at the different species, and it's highly conserved throughout species, but in hominids especially, and the way they track a lot of the hominids and know the evolutionary scheme is because of the dentition, the shape, size, the development, and the genes that are involved in regulating the tissues and the development are highly conserved as well. So up until we became agrarian 10,000 years ago or so, the dentition was, it was critical for survival. They were your tools, your weapons, and if you didn't have good teeth, you didn't survive. David Satcher, the Surgeon General in I think it was 2001, I think it was 2001, said if you don't have good teeth, you don't have good health. If you don't have good oral health, you don't have good health. And it's still true that people that lose their teeth earlier tend to not have as great a longevity as those people that remain dentate. So it is associated with health. All kinds of things you can see from developmental defects. They're highly variable, and you can see changes in color, shape, size, composition, structure, the number of teeth. It can affect one tooth or multiple teeth, the eruption, the exfoliation, the loss of the teeth. Primary teeth exfoliate naturally. The permanent teeth are not supposed to do so. But even the location, position, and some of those things are highly controlled at the molecular level, and we can see those kind of defects in the biological experiment of human beings. So that's what we deal with clinically, trying to figure out what is it, what caused it, and ultimately what are you going to do about it. Parents usually want to know what's it going to cost to do something about it as well. But so this is an example of very severe malformation, and I've got examples of worse ones than this as well, but showing again a hereditary anomaly where you can just have very aberrant structure, shape, morphology of the developing dentition. So I did an OMIM search, and I just updated this the other day. If you go into the online Mendelian Inheritance of Man and just look for missing teeth, hypodontia is missing teeth, and there's other terms used for it, but that's the one I'm using. There are about 137, and that's both syndromes and non-syndromic missing teeth. There are some genetic anomalies that will cause missing teeth, and you have no other discernible phenotype within those people. Enamel, a couple of hundred, dentin, cementum, which is important for teeth to stay in, and it's critical in the hypophosphatasias. 3 of those 11 hits are hypophosphatasia hits. So collectively, there's a lot of different things at the genetic level that we know many of the genes, not all of them, but we know a lot of them, and they're being figured out fairly quickly at this point, given our high throughput technologies for doing genotyping. So there's a lot of diversity in what we see clinically. You're all, I'm sure, very familiar with cleidocranial dysplasia. This is a kiddo with cleidocranial dysplasia and you're probably not used to looking at pantographs, but this is our sort of one of our mainstay dental kind of films. And this kid just looks like popcorn. I think we took something like 20 supernumerary teeth out of this child. It was hard to see exactly where things were. Nowadays, we would do a cone beam. This was a number of years ago, but we would know exactly where they are and which ones to extract. There are other conditions that have supernumerary teeth. There's other conditions I'm not going to talk about with a lot of missing teeth. Clefts can go either way. They can either have missing or extra, but cleidocranial dysplasia is an interesting one. It's rungs 2, multiple supernumerary. One of the challenges is the permanent teeth fail to erupt, especially those that are underneath the they're underneath the primary dentition. Those are termed the succedaneous teeth. So RUNX2 is important in tooth development and signaling so that you end up with these supernumerary teeth, and it's highly variable between cases. Some won't have any or maybe have one, and others like this young lady, this is the young lady from the pantograph, who was referred to me by an oral surgeon without a diagnosis. And I've had several of these cases that come in that have not been diagnosed, even though there were, phenotype was relatively simple to figure out once you looked at them. And in this one, I was doing family history and asking about familial traits and extra teeth. And the dad's like, no, but she can do tricks. You want to see? And I was like, well, sure. And she did this, and it's like, well, diagnosis. But she has frontal bossing and a lot of the features that one would expect to see with Cleidocranial dysplasia. And some of these, the signaling of RUNX, so this is developing tooth bud. A lot of these pathways, again, went fibroblast growth factors, MSX1, transcription factor, sonic hedgehog, important in bone, important in tooth formation. So again, it's not uncommon at all to see developmental defects of teeth that are associated with other manifestations and other tissues. So the multidisciplinary approach is usually where you have to go with these conditions. This little guy, well, he's not that little anymore, but he was on the TV show Stranger Things, I think is the name of it. Stranger Places, Stranger Things, I think. But I had the pleasure to meet this young man and hear him speak at Lobby Day in Washington, D.C. And he was talking about how when he was first diagnosed and was going to places to see how to have his teeth managed, which was one of the main problems that he dealt with, nobody really seemed to know much about it. But it was, now there's the Cleidocranial dysplasia Smiles Family Support Group. And a lot of different conditions have great support groups, you know, the OI Foundation and other ones that are really, really super helpful for families, soft bones for hypophosphatasia, a whole bunch of these. But he was very articulate, and it was interesting to hear him. And they were all on Capitol Hill lobbying for the NIH budget. This was not this year because of COVID, it was a year ago. But very interesting. All the people going into the Capitol building, all the security people were taking their pictures with him because he's a TV star. Management can be very challenging, take years. And again, the dental part of it is not the only part of it that you deal with, but it's certainly a significant part and can take years to manage these cases. So you can have dentin defects are commonly associated with bone defects because dentin has a lot of the same molecular pathways. Type 1 collagen is the most predominant protein in the dentin, just like it is in bone. So osteogenesis imperfecta, like this little girl has, and you could have abnormalities with root structures and other things that can be associated with bone defects. This is a really busy slide, but I put it in here just as a bit of a summary. So in the dental world, we have non-syndromic and syndromic conditions that can affect dentin and root formation. Dentinogenesis imperfecta can either be its own condition, an autosomal dominant caused by mutations in this gene, DSPP, which codes for several different proteins. It is the most predominant non-collagenous protein. Dentinogenesis type 1 is associated with OI and with different types of OI and variable prevalence between the types. Multiple types, lots of different genes, the most common ones being the associated with the COL1A1 and COL1A2, but there's a lot of different genes. But the Silence types are the ones that seem to have the most DI, and the other OI types, the dental phenotype is not as well characterized at this time. But dentin dysplasia is actually allelic, and in the primary dentition looks exactly like dentinogenesis imperfecta, and it's the same gene. The mutations for this, though, seem to be localized on the 3' end of the gene, and the permanent dentition does not look like the primary dentition. This one can be a challenge from a diagnosis point of view, because if you have spontaneous mutation in this, you may think that you're looking at an OI-DI, because spontaneous mutations in this are not very common, and they're not that common here. But the parents may say, no, my teeth are fine, and you look at them and they look fine, but their baby teeth weren't, they just don't remember that. So I've actually had one of these we screened it for an osteogenesis imperfecta, and then when I really went back and looked very carefully at the permanent dentition and took radiographs on the parents, it turned out it was this, and we sequenced it, and sure enough, it was they had this condition and not a new a new OI mutation, de novo mutation. Hypophosphatemic rickets, hypophosphatasia. So there's a whole bunch of these different conditions, and the genes for many are now known. Some of these actually have therapies now. So there's a lot of overlap and connection between the dental phenotypes and the skeletal phenotypes and the diagnostics between these conditions. So if you look at the dentinogenesis imperfecta that occurs non-syndromically or with the OIs, why do they look so much alike? Well, the reason is, I believe, actually, this is nobody, we were going to put a grant in to do this work, and it didn't get funded by NIH, but you have the fibrillogenesis formation of the collagen fibers that are the type 1 collagen. Those interact with the non-collagenous proteins, and again, the DSPP proteins are the most predominant ones in the dentin. And they actually interact and then are helping to form the loci for the initial crystallite formation within and around the collagen fibrils. So, and then they'll go on to nucleate, and you'll have the growth, and you'll have the, within the fibrils, within the gap zones, and it'll go on and mineralize and set the whole thing off. And again, alkaline phosphatase is important in this. You've got to regulate calcium and phosphorus in the microenvironment for all this to happen properly. But if you have abnormal collagen that doesn't interact normally, this is what I believe, this has not been proven, but with these non-collagenous proteins and would interfere with that, or you have normal collagen but abnormal non-collagenous proteins, either one is going to mess up the dentin formation. And so they look very similar between the two because they're linked in the pathogenesis pathway here of how the mineralization occurs. So this is an example of a little kiddo who's got, this is actually an OIDI, and you can see where the enamel is starting to pop away from the underlying dentin. The dentin is not as well mineralized. It's got about 30% less mineral by volume. That increases the water content. The crystallites that do grow in here, and they do, it does mineralize, just not as well. They tend to be not the same shape and not the same size, and so they don't have the same, the dentin isn't as strong and structurally as supportive. So it flexes a bit much, and the enamel will pop off. So you'll see these kind of things, and once you've got the enamel off, the dentin will wear down very, very quickly. So this is a 2-year-old, and the teeth are just wearing down to nothing. The morphology of the teeth can be abnormal as well. They tend to have these constrictions around the crowns. People call them tulip shaped. The roots can be very narrow and pointy. They call them tent peg-like. So a lot of morphology differences, not as well characterized. In my experience, the teeth are also smaller. We did a study in both the DI1 and 2, so the OI associated and non. And if you measure the teeth mesiodistally, we did this off of radiographs, they're significantly smaller than average tooth size. Again, tooth size is fairly well, it's pretty regulated under the genetic control. Not that there's not a fair amount of variation in the population, but the DI teeth tend to be smaller. So they wear because of the enamel fracturing off. They can form abscesses. The pulp inside and the nerve tend to obliterate. So radiographically, they have this rather distinct look. If you do have to do a root canal, that's problematic because they may not have a canal to root around in. And the mechanisms for going down with the little files and things that the endodontists do, they're as likely to perforate and go this way as they are to go the way you want them to go. So they can be very challenging. Can be done, but can be challenging. On top of this, with the OI kids, you overlay what the genetic phenotype is going to be now with environmental, and we have the bisphosphonate treatment of at least the more severe OI cases, which is pretty predominant at this point in time. So that can raise issues. So here's DI type 1, can look just like OI. One difference with DI, the DI without the OI is, as this one is, the permanent dentition in the OI cases tend not to be as severe as these guys. So the DSPP mutations, if they're severe in the primary, they're probably going to be fairly severe in the permanent. With the OIDIs, they tend to be more severe in the primary, less so in the permanent. Don't know exactly why that is, but that's true based on the clinical phenotyping. This was a recent publication that came out, and it was based on the big clinical studies that have been done in Toronto. It's a multi-center study, actually, and they've got a natural history phenotyping, and I thought this was great, looking at malocclusions and also quality of life. a lot of times the dental components of these things are really significant and really do have significant impact on quality of life. So they tend to have these open bites. They're now looking at ways to potentially manage this orthodontically. So, and not published, but both of the DI types, both the Osteogenesis imperfectas and the non-Osteogenesis imperfectas, tend to have a greater frequency of these kind of malocclusions with mid-face deficiency and with these class 3 malocclusions. This is a kid with the DI type 2, not the OI associated, and he's mid-face deficient, and the maxillary dentition is well behind the lower dentition. So class 3 like malocclusion. So you can see that in both of these, and can be challenging to manage for sure. DI is more common with the types 3 and type 4. And again, the bisphosphonates can challenge the dental components in this. So you're more likely to see delayed tooth eruption. This is a young lady who's been on bisphosphonates for quite a while. The average dental age is about 1.5 years delayed, and some of the teeth just don't seem to want to come in at all. So that can be a challenge. This is a young lady that I treat, and if you can see these teeth, normally they come in at about 2/3 of root formation. We extracted baby teeth to try and get these in, and they sat for years and years and years. They may now be starting to come in, but long-term tooth eruption can be a challenge with, and the bisphosphonate probably contributes to that because it's a clastic. You have to have osteoclast to help open up the bone chamber, clastic to resorb the roots off of the baby teeth. This was a kiddo that was up at Toronto, and they said, well, we really recommend pulling these teeth out. And I said, well, we did that here, and it's not really helping, and I don't know if it's going to help here. And we know that this, though, does set up for potential fracture site across here, which might even happen if you pull the tooth out. You could fracture the jaw at this if you're not very careful. So this was a case that they shared with me and showed the fracture here through a tooth bud like this. So the comment that I got was, it's like you're damned if you do and damned if you don't. It's challenging to deal with this kind of thing. Hypophosphatasia, again, this is well known in the medical community, more so with some groups than others. We've had cases where we identified these because of early tooth loss, and it was challenging to get pediatricians to get on board to help manage the case. Alkaline phosphatase is critical for bone, but it's also critical for tooth formation, and it's most critical for the cementum, or the root covering. That is where the fibers attach in the ligament between the bone and the tooth. There's called Sharpie's fibers in the periodontal ligament. If you don't have the cementum, you don't have the tissue here where that attachment occurs, in which case, as far as the bone's concerned, there's really nothing on the other side tooth-wise, and the teeth will get loose and fall out. So that's the dental issue. Tooth loss occurs in all HPP groups. The more severe the condition, the more likely you are to have a greater number of tooth loss. This is most well documented in the childhood and the odontohypophosphatasia, which is considered to be just the dental manifestations without bone manifestations. Not as well documented in what the long-term dental outcomes are in the adult forms. But this is a common type of manifestation in this picture for this little kiddo, where you see this canine is mobile and the roots already being exposed, and they don't have a lot of inflammation here, roots being exposed, and they may not have any inflammation really. There's a little bit of inflammation here, but disproportionate amount of bone involvement and tooth falling out, and they fall out without the roots being resorbed away. So when you're seeing 18-month-old, 2-year-olds with these kind of patterns, this kid's a little bit older, but these first lowers fell out when he was like around 2-ish, a little before. Those are all red flags. And when you don't have inflammation, this ought to be in the forefront of your differential, as opposed to Papillon-Lefebvre syndrome or Shideki-Higashi or one of the other conditions that are associated. Langerhans cell disease, they usually will have more inflammation and other illness signs, other phenotypes than what you see with hypophosphatasia. So again, this tooth, not so clear probably to folks over there off the webinar, but there's no bone around this tooth. So it's mobile and getting ready to fall out. So they typically fall out like this. So when you see this, and they may have a little bit of resorption as an electron micrograph of the root surface, showing a little bit of the clastic resorption, but primary teeth don't fall out like this normally unless they knock them out. They usually, the root dissolves off. So this electron micrograph, this is a normal root. I just took the teeth and I fractured them in two, and this is the normal cementum with all the fibrous looking attachment. It's mostly collagen and mineral, type 1 collagen again, and the Sharpie's fibers would attach into this. This is the root surface on a hypophosphatasia tooth, and you really don't see that fibrous area. And down inside the tooth, this is not well coalesced as far as the tissue goes for the dentin. So this would be cementum on the outside out here, and there's very little here. And then this is the dentin, and the dentin, because the alkaline phosphatase is important in regulating, again, the pyrophosphate and phosphate, and kicking the whole process off of dentin formation and mineralization of tooth in general. They'll have defects in the mineralization of dentin frequently. And again, the more severe the defect, the more likely they are to have defects in the dentin. You don't see this clinically because the tooth is covered up, and I mean, you don't see the cementum. What you see is the crown. And in some cases, they will also have enamel defects. Many of them don't. They'll be quite normal, but you can have enamel defects again. And that may be because at the outset of a mineralization between the dentin and enamel as they form up against each other, and the whole mineralization show kicks off. Alkaline phosphatase is important in those early events. This is interesting because this is the teeth form from crown down. So this is the first part form, and this is near the end of the crown, and it's like fizzling out here and not doing well in this particular tooth. The majority of cases I see don't have enamel defects, but it can also occur. So it can be dominant, it can be recessive. The craniofacial manifestations will vary. They can be brachycephalic. I mean, they can have craniosynostosis and all the other things, and you folks are more familiar with that than I am, but they can also have these open bites and also have cross bites. So skeletal aberrations in the development of the jaws are also not uncommon. Not well characterized, but also, in my experience, not uncommon. Again, there's not a lot out there about the adults in this particular survey that was done at Duke on the here in North Carolina. They looked at adults, and I pulled from this article that they had 44% of them had root canals and 16% had implants. Both of those suggesting they probably had, no, both of those are higher than the general population that one might see in the United States in this area for the age group that these people were, suggesting that there's probably an increased burden of oral disease in this population that, again, has not really been well characterized. So there's opportunities for studies to characterize these populations and better understand this. That's David Satcher's quote. And you all are very familiar with the enzyme replacement therapy for this. And one of the questions is, will this rescue the dental phenotype? And there's a lot of growing evidence on the bone and some great stories and studies actually at this point showing the rescue of the bone phenotype. Not so much in humans on the dental phenotype. There are studies that have been done by Brian Foster and others that looking at the dental manifestations, and it appears in the animals in the mouse models that you actually do get rescue, and you'll have the normal cementum formation, and that will give you the fidelity of the dentition. In the humans, there's case report, and that's it to date that I can find. If there's something else, somebody shoot me another reference, but this is what I found, and this is July of this year. And what they reported here was that they had a couple of mobile teeth when they started. So they identified the kid at right at 2-ish. They started the kid on aspartase, and then these two teeth fell out. And they've got radiographs showing that the teeth already had bone loss around them at the time. They said that the exfoliation of two mobile deciduous teeth was triggered by catching a cold at 2 months after starting therapy. I don't think the cold had anything to do with it unless he sneezed really hard and blew him out, but I think they were headed that way. I think my take home from that is if you've already got a lot of bone loss, you're not going to regenerate cementum on teeth that have already formed, recruit new cells in and do all that. So unless you start therapy prior to which time that these teeth would be developing, which these roots on those teeth would be developing late in utero to early postnatally. So you'd have to be treating very early on to rescue that. You might rescue part of it if you got, if you even started at birth and you knew, because part of that root would still be developing postnatally, because these teeth erupt in, and these are 6-month-old on average. So that's all that I've been able to find on hypophosphatasia in kids. So with that, I'm 35 minutes into this, and I'm going to stop, and I'll take any questions, and then I've got a case for discussion.
Tim, thank you very much. That was an extraordinary adventure